Hey guys, welcome back to the Vitality Code podcast. I'm one of the two co-hosts of the show, Dr. Jason Farrah. I'm here with my well-bearded, magnificently bearded brother, Dr. Jeffrey Farrah. Say hello, Jeff.
Good morning. Good morning.
Hey, I have real quick off the bat.
I know exactly what you're going to say.
I'm so intrigued by that beard, man. What is it's not got product in it. You know what? It looks more
100% it has product in it.
Producer Nick, look at that.
You think this just comes naturally? Please. You got to work for this.
It looks more Thor Viking-esque today. It's a little more fluffy and a little more. Did you put a volumizing product in there? It looks massive.
I don't
today.
put a volumizer, but yeah, I haven't groomed it in a couple days, so it tends to get a little bit out of control. But it does have. I do more beard product than I do any other kind of product, for sure.
We're seeing it in its natural state. Well, do you now? Hey, here's a question: when you go out in the sun, do you have to put sunscreen up top?
Well, that's a good question. That's an argument in my house. That's an argument in.
That's a whole health topic in to itself, right?
I don't wear sunscreen,
but you don't want to burn either, right?
Yeah, but I mean, my head's exposed to the sun 24/7. Here's the thing: it's exposed to the sun 24/7, 365. I don't wear hats. I'm always outside. Where I'm in Florida, so it never burns. But the flip side of that is it's 24/7 exposed to the sun. I don't want to be getting skin cancers on my head and having to get all those treatments when I'm 60.
And you've already had one.
Had one on my face. Yep.
Basal cell. So, but you don't go to the beach and just lay out for the purposes of sun exposure and sun exposure only.
If I'm out in the jet skis, if I'm out in the lake, I will put sunscreen on my head.
So is it a
conscious for continuous time?
Is it a matter of convenience or a matter of conviction, the sunscreen?
I would say
meaning like it's annoying to put it on?
Both. Okay. There's a significant amount of chemicals that leach into your bloodstream.
That's where I was going with that, yeah.
From sunscreens, and it just doesn't make sense to me. I also, though, sort of play the middle of the road.
What's worse, or the...
Right, but I play the middle of the road. I'm also, if I'm going to be out on the jet ski in direct sun, zero shade, zero in and out, no trees, and I'm going to be pulling the girls on the jet ski for 3-4 hours, that's an abnormal situation, so that I put sunscreen on.
Yeah. So you have a massively reduced exposure to it than one would, the average American that's getting sun exposure. I think that's a good thing to do. I mean, you got to be smart.
But on a daily basis, I don't put SPF,
Yeah. Hey, so I'm really excited about what you guys, and I know this, it's kind of a self-serving thing to say, but this is a genuine thing. I'm really excited about what you guys are doing at Midtown in Tallahassee. And so a lot of what you do has intrigued me over the years and more so recently in all areas of what you're doing. But most especially, you and I have been talking more and more about medical weight loss. And I love your model. And we'll get back into that later, hopefully on the show. But I wanted to ask you, what do you think about medical weight loss drugs? It's all the rage. It's all the fad today. The Kim Kardashians and the, I don't even ask. She just labeled everything. Maybe she's not even, but right. Hollywood stars and everybody.
Jane down the street.
Now it's our neighbor. Yeah, everybody's taking semaglutide, Ozempic, whatever name you want, and then tirzepatide. Those are the two big ones: tirzepatide, semaglutide. Are you guys doing that at the clinic? I think you are, aren't you?
We are. I resisted for a good bit, some time.
Let's stop for a second because I did too. I want to explore that. Why did you resist?
So if I'm honest, I was just personal reasons. It was nothing medical. I just felt from an emotional standpoint, from a personal biases standpoint, if I'm honest, like this is not the way it quote unquote should be done. This is probably not going to work well. There's going to be some unintended consequences that are going to show up. It's not that you're cheating, but more like it's just not a long-term successful route. And if you don't change your healthy habits, you're not going to get a win. And so you shouldn't do this. And it's a slippery slope. And then my first script was actually a medical professional. She was a nurse. And we were just talking, having an open conversation. And she's
overweight or obese?
Overweight, not obese. Wanted to lose a moderate amount of weight, 20 pounds. And she said, so you don't have a medical reason why you won't write the script? I
said, called you out, man.
Yeah. I said, yeah, I guess I don't. She said, then, She didn't say this verbatim. She was basically saying, this will write the damn script. And I said, you're right. I don't have a medical reason. There's no significant contraindication for you. There's no significant thing that I'm concerned about. We talked about the pros and cons. We talked about some of those relative risk factors and things like that. But at the end of the day, I wrote the script, and she had such a positive response in other areas as well that it sort of changed my mind, and it made me think that one of the things that I really hold true and near and dear to my heart is patient autonomy. And I was sort of breaching that very own ethos within myself by instilling or attempting to instill in her what I felt should be done about this problem rather than what she felt and what she wanted for herself. And honestly, that's just not something how I like to practice. So I had to reevaluate it.
Yeah, because there's the principles of maleficence, beneficence, and then they can get conflated or kind of crosshatch, or Venn diagram over with paternalism, maternalism,
Yes.
and taking away of patient autonomy. So it sounds to me like you said, wait a second, or she actually said, and you accepted it, that no, it was an actual true bias that weight loss should be approached from lifestyle changes, not necessarily dependence upon a medical drug.
Yeah, that's true.
And a bias rather than a medical reason. Oh, I don't want to give you this. I suspect maybe I'm worried about it, but I don't have an actual real named medical consequence of taking this medication that I could say that I'm trying to help you avoid. And I don't, again, beneficence, maleficence. I don't want to, first do no harm. It wasn't that. It was, do you really need
right.
it?
It wasn't, you have thyroid cancer, or, oh, you have a history in your family or yourself personally of chronic pancreatitis. It wasn't those things, which is, I have a duty to, like you said, I can't cause harm, but it was just to wrap it up in just a very simplistic way of saying is like, if you need to lose 15 pounds, just buckle down and lose 15 pounds. And that was sort of my approach, but that was it what she wanted. And that had to be honored, I felt like. And she knew the pros and cons, risk rewards. There was no absolute contraindications why she shouldn't take it. And so she was willing to do the time, effort, and money and, relative risk. And so why shouldn't she be allowed to use this medication? And had great results from it subsequently, which, was
Tell me about her
good
results.
So she lost the weight, which wasn't a deal breaker.
How much did she lose? Do you know?
I want to say, I don't remember. It was 15 to 20-ish, not a large amount. But the big thing that changed for her was alcohol consumption. And that was my first patient that I had that report from. Hadn't seen any reports anywhere else, and it was quite interesting, and it made sense to me logically at the same moment. But she was literally in tears because she hadn't drank in X amount of days or weeks, which had been a long time for her. Not an alcoholic, but a functionally, social drinker, and at home with the husband or by herself.
By herself. Okay, so she's drinking.
Yeah.
So you get into those cage questions. So maybe she was flirting with alcohol dependency. I mean,
yeah. I mean, there was some,
because she cried. She cried.
Yeah, it's something that she struggled with personally. Had wanted to give up, had wanted to limit, and was unable to, and had noticed that as a byproduct. We hadn't talked about that before as a potential outcome or a reason we would or wouldn't do this. But she was drinking 4 to 6 nights a week and was down to like several weeks without a drink. And that to her was a huge, huge thing. And so that obviously reinforced my previous decision. She had a good response, lost the weight, was safe, was judicious with it, didn't overuse it, whatever those things were, and had an ancillary positive benefit. And so I had to just sort of start looking at my perception. And that was sort of the genesis of how we started writing it in our office.
When you say she didn't overuse it, what do you mean by that?
Well, there is still some subjective side effects that come from, I find that patients in my office, I tell people I'm not a go big or go home kind of doctor. I was trained as primary care. I feel like primary cares, at least how I was trained, you're taught to be nervous a little bit about everything. Like you have just enough information to not really fully understand cardiology, rheumatology, oncology, but the warning signs. And so you get nervous of those. So you're just taught to be scared of everything. So one of those things was like,
but that translates into you're not operating out of fear necessarily, although, first do no harm. So there is that component, but then that leads you, it sounds like, I would just caution you don't belittle yourself. It sounds like you're trying to be more methodical and deliberate because of the fear.
Sure,
Yeah.
yeah. But because of that, there was this idea that you could lose too much, you could lose too much muscle, you could become, sometimes patients, when given control, we feel like in medicine that they're going to do the wrong things. And so in my experience in my office, there is a certain subset of patients individually have a makeup that if a little's good, a lot's better. And so when you push the weight loss and you push the trajectory with these drugs, you run into more of the side effects. So you run into more nausea, constipation. You run into weight loss that can be really rapid and really quick. So therefore, subsequently, you, lose a lot more muscle as opposed to just fat, and you can lose facial fat, which makes you look aged. And those are the subjective. Some of those are subjective. Some of those are objective problems. But a smaller dose tends to prevent a lot of those.
Right. I think I had the similar. So I, more my setting was in the acute, more my medical training, and more my prior to doing this was treating surgical disease. Obesity is a surgical disease at some level. In the case of there's bariatric surgery, for instance. So I got a lot of exposure to that, a lot of teaching in that in residency, and then as an emergency general surgeon and trauma surgeon, critical care surgeon, dealt with the fallout from that or the complications from that and so forth. But I also dealt with a lot of where I ran up against was the scourge of chronic diseases that obesity sets the stage for, actively contributes to, and makes worse. and so some of it was my attention was just pulled elsewhere into treating the complications of it, and then some of it was lack of understanding, honestly, and feeling like, oh, maybe you could, with lifestyle changes, and you can. It's not that you can't affect changes without having to have a drug. And as a surgeon, my first tool is going to be manipulation of physiology and my knife, right? That's is not going to be dependence on a drug per se. So
whereas my first line is going to be, dependence on personal lifestyle habits and change, not a drug.
That's interesting, right? So we are both coming from it, two different realms or two different vantage points, but with similar thoughts. That's interesting.
Similar outlook on a drug, right? Yours was on one end of it, and mine was on the other end of it.
So, there was the overwhelming desire to have these drugs, and people that came in and qualified, quote unquote, qualified for them with their status of overweight or obesity. Just using like I think it was the Surmount one trial that came out in the New England Journal of Medicine in July 2022 last year with tirzepatide. So they were looking at people that were obese, if they, as defined for them in this study as a BMI of 30, and then if they were BMI greater than or equal to 27 with one complication, sleep apnea, diabetes, type 2, severe osteoarthritis, different things like that. With, I think the standard of overweight is BMI greater than 25, but we know how that can be. That's tough, right? Is it muscle, and that's the reason why you're over 25, or is it, is it fat? So anyways, they would come in, and there was a desire for that, and I felt like I was helping, but I still kind of had some reservations. Then I saw the dramatic results, and that was I was pretty blown away by that. This is a game changer. This is a game changer in the world of medical weight loss.
I practice out of a healthy, even though I live in this industry and do this every day, I still have a healthy skepticism of medication as a line of defense for primary care and for chronic conditions. But it's been an interesting experience for me with this drug specifically.
I do too. And I think we would all prefer that patients be able to make lifestyle changes. In fact, honestly, if they were honest, and we were, and we were all vulnerable, sitting in a group of physicians and practitioners, healthcare practitioners, and patients, yeah, they would love to. They just feel for whatever reason, and there are a host of reasons that they can't make those lifestyle changes, or it won't work, or and that gets into a whole range of different topics. But I think they would too. But the reality is they don't. And you and I have talked about this for, I mean, at least sounds cooler to say decades, but at least 20 decades, multiple decades, 20, 25 years. I mean, we have talked about this since we were in college, working out together, and you were getting a kinesiology degree, exercise physiology degree, et cetera. And we were both in high school athletics, and then you were on to college athletics. So in the different athletic pursuits have been part of our life for forever. And we've talked about this forever. And one of the big frustrations then for us, and correct me if I'm wrong, and because I just, I saw it in you, and I know it was in me, is how do you get people to make those changes? And you try this method, you try this method, and it's just so hard for people to make those changes. It's so hard to help people make those changes. And when they're lasting, these medications came along, I saw these big time weight losses where you're talking 20% of body weight, 25% of body weight, 15% of body weight, whereas clinically relevant body weight loss begins at about 5% of your body weight. And the medications available prior to this class of medications, you had anywhere from 3 to 8%. And you were thinking of things most recently like the stimulant drug, I'm blanking now on. Phentermine, exactly. And those things.
Yeah, which I hate.
And it has, big time afterload, meaning peripheral vascular resistance problems, and you have cardiac dysrhythmias probably, and it's a controlled substance, and you can have addiction, physiologic addiction, everything. And so I saw this, I said, well, maybe there is something to this. And then in treating these people, and then in looking at the research, I came across the concept in my patients, and then in my patients, you would see that diabetes and obesity go hand in hand. That's obvious. Everybody knows that. But I don't think, even from my, I'm 47 now, and I graduated from medical school back in, I don't even remember, 2001, so it's been 20 years. But even the classical diabetes literature and understanding of diabetes and glucose homeostasis has changed radically since then. Even not so much change as more have been added to it, right? And what I mean specifically is I shared this concept with you recently over the phone. We were talking about it, whereas, in the case of type 2 diabetes, you had the classic triumvirate of beta cell failure of the pancreas. So you have decreased insulin output, or you just burn out your pancreas because you're higher and higher amounts of insulin. And then insulin resistance, both in the muscle and in the liver. But I never, right when I was in medical school, we started talking about leptin and ghrelin, and those were very promising knobs or dials to maybe turns out medically, maybe not so much just yet, or maybe we're coming at it from a different direction, and that is the incretins. And then, so this class of medication are the incretins. So you have in the case of semaglutide, you have the GLP-1s, receptor agonist. So this is a naturally occurring hormone that you find in your body. And then on the case of tirzepatide, you have a dual function where it's a little bit less the GLP-1 and more of the GIP, classically called gastrointestinal inhibitory peptide. And then I always have to write this down and remember it this way is read it as glucose dependent insulinotropic polypeptide. So GIP, we'll call that GIP for short. GIPs. And then that's your GIP. And then the GLP is the semaglutide. Is the third one that's been identified that plays a minor role. We don't really know. And you see these receptors specifically, the GIPs and the GLPs in almost every end organ tissue in the body, brain, bone, kidney. Amazing. So there's been two major, I'm kind of getting off on a little bit of a tangent here, but just so people know, to kind of set the background, there's been two major groups of investigators. There's, in the case of the tirzepatide, there's the SURMOUNT investigative group. And then in the case of the semaglutide, the SURPASS investigative group. And then there's been a whole host of trials. Most recently, did you hear about the one that just came out and was stopped early? It was the FLOW study.
Is it the one that stopped early because of success?
Stopped early because of success. When is it?
Can I tell you how this is down a tangent, but the reason I found out about that study was from a stock alert. So I don't own any of these stocks, but I follow
Yeah.
them because I have found that Wall Street sometimes releases information um, prior to the
It
medical
all comes
history.
down to the, geez.
It does. And the reason it came up was and I don't know, but the study got stopped early because it was successful for protecting end stage renal disease or kidney failure, if
Yes,
I'm not mistaken. And the
correct.
previous drug for that was tanking on the news that semaglutide was
Yeah,
adding a better protective effect. And so that's what led me to even finding that study, which I thought was kind of funny.
it is funny. It's a sad state of
Sad funny.
affairs. Yeah, it's both. It's tough. I always struggle with this because I'm all for free market capitalism. I'm not
Sure.
for manipulation of people and results just for a buck. And ugh, it's just disgusting when that happens. And I'm sure it happens more than I even know, or you even know, or than all of
Of
us
course
even
it
know.
does.
Of course it does, right? But on the other hand, I don't have billions of dollars. You don't have billions of dollars to spend on research,
Nope.
and this research needs to be done. So it's tough, right? I think that's when you start to have to really look at the study design, how it was conducted, how it's carried out as best you can. And I got to tell you, a lot of these studies have been sponsored by Eli Lilly on the one hand with tirzepatide, Novo Nordisk, if I'm correct, on the other hand with
Mm-hmm.
semaglutide. But the study designs, especially the ones recently, are very good. They've been carried out very well. The data has been analyzed very well. And here's the kicker: is that you're just telling me now, and I'm telling you that we're seeing the exact same things reproducible in the clinic.
Right.
So, the with this particular drug, more than I have ever seen in my career as a physician, I've been very pleased with the conduct. I mean, I'm not some guru.
You don't have to go down a rabbit hole or defend yourself here. You can.
Yeah, I
We
mean, I'm
all
not
know,
right.
right? There's an unholy alliance between pharmaceutical companies and working for the dollar, but also it makes no sense for anybody other than Novo Nordisk to spend millions and billions of dollars
Yeah,
to investigate it.
yeah.
I'm not going to spend thousands of my dollars. I'm not going to, So somebody has to do it. I think it's the unholy alliance between the regulators and the producers from the critical eye of looking at data and the ability for these companies to easily manipulate those who are in charge of the safety and the regulatory mechanisms of them. That's the problem. Them as a company is not a problem. Regulation as a ethos or as a product of which our government runs out of is not a problem. It's when the company can so easily, quickly, unethically, and unequivocally manipulate the regulatory bodies that they're supposed to govern. That's the problem.
Right,
And
right. I
so
agree.
it exists, and you can't put your head in the sand, but you
A
also
lot of these trials they fail, and it's a very risky venture, honestly. So yeah. So I think there's a lot that goes into it. Nonetheless, as a non-statistician and I don't have my master's in public health, but these studies but I'm a critical reviewer of literature, and these studies are pretty well designed, well reported, and they're pretty impressive data points and results. The flow study. When's the last time you saw a study stopped for good results? They were so overwhelmingly good. They said, we don't need to do it. I mean, I haven't, I don't,
MAPS is seeing that right now with their phase 3 in PTSD and psilocybin. Not stopped, but they're getting advanced movement. And I don't know the official protocol of moving through those steps, but MAPS has done a great job with their psychedelic research. So you're seeing that same. Their benefits are phenomenal for psychedelics and PTSD, but we won't go down that rabbit hole.
but in the course of your,
Yeah, no, it's not common at all.
it's not. So I was shocked to see one stop for good results. But have you seen? I've seen them stop plenty in the past for mortality reasons or morbidity or not, non-viable.
Well, one of them's right in our wheelhouse that we talk about commonly
What's
for
that?
hormone replacement and
Oh
Women's
yeah,
Health Initiative.
yeah. Oh gosh, yeah,
Which
exactly.
was stopped, and now we have a critical eye going back looking at it, and you're starting to see. It's funny to see all that talk now coming up when we've been having that conversation for a long time, and now all of a sudden it's trendy talk.
Yeah, when you were first embarking, and I kind of was and you were working for me, so to speak, and before you become
Yeah,
a
well,
solo
you
practitioner.
introduced me to that too, and I was
Yeah.
like, that's my. It was my perspective that you could not do these hormones for women because you're going to give them cancer, and you challenged me on that. And I remember thinking like, let me look into this myself, and then now you're seeing everybody, not everybody,
Oh,
you're seeing a
so it's like,
big
yeah.
bandwagon of like, oh, the Women's Health Initiative, and
So the thing that I realized in looking at the literature is this whole incretin pathway has been massively understated or underestimated, just due to the its clinical relevance catching up with the science being always ahead, right? And then getting that into the practitioner's office and then getting people to understand it. And I didn't quite understand it to the degree of which is important. And what I mean by that is when you look at the obese and overweight patient and the glucose homeostasis and hormonal homeostasis, frankly, for that matter, of many other endocrine hormones, including insulin, obviously, and testosterone, it's massively disrupted, and the internal milieu is predisposed to keep an overweight person overweight, and and the counter regulatory mechanisms in that you come across in your own body when you begin to do lifestyle changes is massive. There's a researcher, Ralph DeFranzo. I had his name written somewhere here. Yeah, Ralph DeFranzo, I think, and he's out of the University of Texas Health Science Center. He has the most NIH grants rather, in diabetes research. Guy's amazing. And he came up with this concept, or at least he promulgated it, of this ominous octet. We went from the triumvirate of beta cell failure, insulin resistance in the muscle, insulin resistance in the liver. Now we show that this octet of obesity and diabetes, we have the muscle and the liver and the beta cell as above. Those are the three, right? Pancreas, muscle, and liver, and then even the accelerated lipolysis at the level of the lipocyte or the fat cell with excess glucagon. And so you have a breakdown, and then you have free fatty acids causing problems in the bloodstream and at the blood vessel wall and in the liver, gastrointestinal tract. And so here was the key, right? Was the incretin deficiency resistance. We'll come to that and back to that in a second. The alpha cell in the pancreas with the hyperglucagonemia, the kidney with the increased glucose resorption, and the effect of the diabetes on the kidney, a la flow study. And then even in the brain, the level of insulin resistance and the effect of the hypothalamus. And those two, the brain and the gastrointestinal tract, to me, have been phenomenal in their effect, in how they're affected by these drugs. And so what I see is with the trend towards diabetes and the overweight person and the obese person, they are going to have an incretin deficiency or resistance, just like insulin. So, and they might.
Why don't we back up? Why don't we pause there and back up and just tell us? So these are incretins, correct? The semaglutide, the tirzepatide, which are those chemicals released from the stomach.
The line of the intestinal tract of the pancreas specifically, okay, and they're going to have exocrine, endocrine effects. They're going to go through the bloodstream and go elsewhere, and then have local effects, exocrine. And
so, what are those effects specifically that aid to the weight loss that patients are seeing?
So, at the level of the GI tract, it'll slow gastric and overall GI motility. Okay. And in the case of tirzepatide, for instance, that this gastrointestinal inhibitory peptide, I like to call it by its old name, you have in your distal ileum, so you have your mouth, your esophagus, obviously, stomach, small bowel, duodenum, jejunum, and then the last part of your small bowel, the ileum, right before the colon. There's a braking mechanism called the ileal brake, and it kind of enhances that. So again, this is leading to the constipation issue potentially.
Right.
So the thought
is, funny that's how I describe it to my patients too. I go through the effects and I say, well, that leads us to our first side effect, right? So
exactly.
Yeah. So it makes a good flow, right? So the first effect is a slowing of the gastric emptying, right? The entrance of food through the exit of food just kind of slows that process down. Is that
exactly?
A way to
feeling so how does longer.
So you feel fuller longer, so you have less of a stimulus to eat.
And everybody knows that one, right? And everybody, and when you explain on the surface level, it makes you feel fuller longer so you don't eat as much. Okay, and that's good. Less right? And so we need, you know, I think it was the most studies show you need about 700 kcals a day less. And you need to increase your energy expenditure by 25 to 30% to significantly lose weight and sustain that. So if you're eating less because you feel fuller, because of the mechanical receptors, right? The mechanical action
It's that
on
stretch, right?
the stretch, right? And the different things. Exactly. So we're gonna see that effect. Okay. Then at the level of the brain, the hypothalamus should, if you eat a high glucose meal and you have an insulin response to lower the blood sugar back down to normal, that insulin should tell the hypothalamus, whoa, buddy, you're eating too much, slow down. But just like um, all the effects that the diabetes and the obesity have on, in fact, the new term, I don't know if I said it right in the podcast, but it's diabesity. So they're so hand in hand linked, diabesity. So you got these people that are trending towards diabetes and obesity, and they for all intents and purposes, they basically have diabesity. And so the hypothalamus doesn't respond to that signal anymore. So these people, and that's
Is
what
that signal you're talking about? Is that the appetite suppression component to it?
Yes.
Okay, so that comes
it's
from incretin stimulation of the
yeah.
hypothalamus,
So
or the
incretin,
insulin as well.
both. Okay, and then you've got leptin and ghrelin working, and that's, we can talk about that another time. But so as you become insulin resistant, insulin no longer has that effect on the hypothalamus. As you become either GLP deficient, because there's just not as much around, right, or resistant, you're not having that satiation effect that you should have. And so, and it turns out, what are the best foods if you wanted to make somebody more obese, if you want to make somebody gain weight? Well, they're going to be foods that are high in glucose, high in calories, low in nutrition, highly processed foods, the different, oils and processing materials that go into creating these foods have a higher disposition to do that with a greater degree of efficacy than natural foods that we all should have been eating, that we've been eating as a species a long time before the Industrial Revolution, and then the post-industrial revolution, McDonald's on every corner effect, right? And we have these hyper palatable foods that are full of these processing because they want to make them taste good. And some, I get it, but it turns out it's at everybody's detriment. So that's what shocked me, was that these people they really are behind the eight ball. And the longer you are in that state, the further you are behind the eight ball. Let me give you an example. So if somebody comes in to your office and you see a hemoglobin A1C, let's say you test their hemoglobin A1C, they're going to start out with you. Maybe they in this obese state, they want to lose weight, or any kind of state that they're going to get comprehensive labs, and you get a hemoglobin A1C and you see a hemoglobin
I do it screening on all my new patients.
Okay, so it's 5.5, 5.6, right? Under that 5.7 pre-diabetes.
I tell them my scale is like when you were 18, 19, you were in the 5.1. That's optimal. 5.1, 5.2, 5.0.
And then let's say you see, and they're fast. Let's say you see the fasting glucose 120, and it's not over that 126 mark, right? You're like, yeah. So they're not diabetic, right?
Correct.
Okay. So then you take them. Let's say, for instance, take this group of people, and this is in DeFranzo's. He's got a 2009 paper. He did a 2019 address that you can Google, talking about the weight reduced state and the physiology and behaviors, inventions, etc. But if you look at those folks, and that group in Texas is amazing, the work they're doing, and you subject them to an oral glucose tolerance test, okay? And let's say 10 of those people, let's say you got 30 people, 10 of those people are in that upper tertile, where they were like 129 to 120 to 139, excuse me. So below 140 at 2 hours, you're not diabetic. And they say, oh, look, your glucose is 139, not diabetic. And they're like, hooray, good. Well, when you look at their function of their insulin, you measure their insulin secretion, and you measure it in response to glucose over time, and you compare it to healthy controls and quote unquote normal people, they are way off the charts, meaning that these people have a normal glucose and they look non-diabetic because they have higher circulating levels of insulin, way higher than they should have. And if you look at it, then you can plot the function of the pancreas as defined by there's an index. It's the gold standard, basically. It's insulin secretion divided by insulin resistance. It's called the disposition index. Okay, and you basically are looking at their change in insulin levels over the change in glucose over time, and then you're dividing that by insulin resistance by other variables that they have defined and set out in this paper, for instance, the study, and you can map their beta cell function. And these folks that are in their 120 to 139 upper tertile, they're normal, right? They're quote unquote normal. They've already lost 2/3 of their beta cell function.
2/3?
2/3.
Does that equate? Do you remember? Does that equate to an A1C level?
I don't know exactly, but it's going to be normal.
It's going to be normal, so it's going to be 5.6 or below, or 6.3 and below.
So normal as in non-diabetic, meaning for the scales that I use do you use Access Labs?
I think
you're the one at Access Medical. Oh, you predominantly.
Yeah, but I use predominant. That's just the HMO that practices in my town.
I'm thinking 5.7 is where you become pre-diabetic, and
pre-diabetic.
Yeah,
6.4 is diabetic.
Yeah, so I'm thinking anything below 6.4, anything below 5.7, even really. Okay, so you got glucose 120 to 139. They've already lost 2/3 of their beta cell function. So really what we should be testing maybe is not glucose, but maybe we should be testing people's insulin levels, basal insulin levels, and maybe we should be testing oral glucose tolerance tests and looking at their insulin resistance. By the time you get to abnormal, okay, in the upper, we call the upper tertile of abnormal, where you have a glucose of 180 to 199, after in response to the oral glucose tolerance
you're
test,
diabetic.
You've lost 85% of your beta cell function, and that's like
impressive. Wow,
just starting out. Yeah, and
these are type 2.
These are type 2 diabetics. They're not on insulin just yet. You can. So yeah, there he is, Ralph DeFranzo. This guy's amazing. The work he's.
I have to look into that. I'm gonna write that name down.
The audience really
I do
should.
a lot of A1C and I do a lot of coaching in pre-diabetic range, but I don't think I've looked at his work before.
If there's anybody you want to look at their work in the world of diabetes, Ralph DeFranzo, DeFronzo. That's the guy you want to look at. Unbelievable. So when I saw this, I was like, holy cow, it shocked the hell out of me. Just like it's like I can see on your reaction to it, shocking you.
2/3, that's huge.
2/3. You only got 1/3 of your pancreas beta cell function left. And not to mention all these other things that are coming out, lipodystrophy of the muscle, just on and on. The body just is not made to eat these types of foods and sustain these levels of glucose and insulin, and it turns out the incretins too.
Yeah,
so
I would say. Go ahead. I was going to say I've seen because a majority of my patients, I can effectively say, have not been what you would classically visually say are obese, have some weight to lose.
There you go. Exactly. I'm going to pound the table on this.
The response they have from losing that 15 to 20 pounds has we've talked about this before in previous episodes, that halo effect of testosterone. There's this halo effect of weight loss, not just an aesthetic, but that we can go down that road, but like they just are sleeping better, they're feeling better, they're drinking less alcohol, they're more encouraged to eat better, they're more encouraged to exercise, and they just look. I can tell when they come in the office. You can see their face, and there's this weird like halo effect that comes from these medications as well. When you have what we've called non-visually obese people, because we've been jaded to think of these,
we've had a set
400,
point. We've had to change the set point,
right?
Yeah.
And
yeah,
so
my 400-pound life. Oh, that's obese. There's a lot of people walking around that are obese,
right?
And we just say, it's just the way it is, and because we've been conditioned. It's a set point change. So let me tell you how I got to this. So the reason I started researching this in this level of detail is more and more patients were wanting to come in and avail themselves of these medications. Okay, that's obvious. And you have to use discretion, like you said, and it needs to, you need to counsel people and be very careful. I'm not saying that we just want to be, shills, and we don't want to be like, shilling semaglutide, and just that's all we do. We're trying to help people. And so in that context, though, there were people that weren't getting those results that they should, right? And I said, well, why is that? And I started looking into the thing. So it turns out it makes sense now, right? These are the people, especially with semaglutide. And I would notice this too. I would notice that people, there was a certain class of people, and tell me if you've seen this in your practice, where you would put them on semaglutide and you would gradually get up step by step to the max dose, and they would have little to no effect. And it was kind of perplexing where you'd have the other person that came in before them lost 25% of their body weight, high fiving you, they're happy. What's the difference? What, and you can, intuitively there's something. Turns out, and I mean, this is borne out in the literature, these people probably, and I don't know because I haven't tested their levels in this, probably a send out lab or maybe even an experimental lab, but to measure you can measure incretin levels, but these people are probably people with GLP resistance or deficiency and or resistance.
Interesting.
So you'd have some people that would get to their step 2 in their stepwise ramping up of the medication, and they'd have to stop because they lost so much weight. Some people you have to, so those people probably have deficiency, and you have to overcome that deficiency with higher doses, right? And then there was some people that we had that would max out nothing. And so
this is probably really good information for physicians, because we are seeing this, and I never have critically thought of it from that realm, but you have patients who are exquisitely sensitive to these medications and lose weight rapidly, only have to get to the starting dose plus maybe week 6, and they're, we measure in units, so they may be doing 10, 12, 15 units, which is a baby dose. And then you have some who are blowing past that and getting up to a full ml injection and not getting the results. And they're like, and we always use the standard answers like, some people are more sensitive to medications and some are not.
Right,
but
right.
That is an interesting one. I think that physicians would be really interested, is you can actually have deficiency of these incretins and resistance of these incretins independent of other mechanisms,
right?
Which would then lower the efficacy of the semaglutide or Mounjaro.
Exactly, independent of other mechanisms, but typically commensurate with obesity and the level of how long it's been around.
Right, yeah.
Okay, so somebody that's dealt with their whole life, they're going to probably be. So we see that with diabetes too. So not only is it good though for physicians, it's good for patients because they get frustrated. Why my girlfriend Jane, she lost all this weight. Why am I not?
Right.
Different story, so, and here was something that came up early on too, right? The newer medication by Eli Lilly, tirzepatide, and both are available, right? And you say, they're like, which one should I do? And if you look at the studies, for instance, the one that came out in New England Journal of Medicine in July 2022 from the Surmount Investigative Group, I think the title was tirzepatide once weekly for the treatment of obesity, right? And you look at the trials for semaglutide, the weight loss achieved were similar. Now, you had a greater percentage of people achieve a greater percentage of weight loss with the tirzepatide, but in general, if you look at the means and the averages, they're about the same. So Eli Lilly's drug was newer. It has a dual action. There's reasons why. Those are two of the reasons I believe, but it costs more, right? So the semaglutide. So I just tell patients, if you look at the studies, they're about the same. Just use the cheaper one. I never had a construct, a biochemical and a clinical construct of why they would use one or the other one, right? Turns out now we've seen the cardiovascular, but besides the flow study, the cardiovascular effects have been pretty dramatic in decreasing heart attacks and so forth like that. But for just obesity now, why would I use a tirzepatide? Well, you would use it if you're a GLP deficient, or if I've maxed you out and you're not losing weight, you're probably GLP resistant. All things being equal, right? If you're somehow overriding the mechanism, you're eating, not exercising, and we're going to get into that in a second, but all things being equal, you probably resistant. And so you literally need the other medication, tirzepatide, because when you look at tirzepatide,
dual action.
Well, not only is it dual action, but if you look at the pharmacokinetics, it hits the GIP receptors with much greater affinity than it does. It's more. It's like a GIP with a side of GLP, whereas semaglutide's the GLP.
All GLP.
Yeah,
right.
And then we would do that, and boom, these people would start losing weight.
Yeah.
And so what I've seen in my clinical practice, that's another pearl to take away from that. Now, one of the big things with adherence to a medical regimen is setting expectations, number one. Number two, and I'm sure you'll agree with this, number two is getting results, right? So then those are part and parcel, and those are hand in hand. So one thing that people have to remember is when they come in to take these medications, and this is where critically looking and not just reading the abstract, reading the whole entire thing through and understanding where they're coming from, it helps the clinician, is to set those expectations. When they're talking about Kim Kardashian, Hollywood folks, or Jane down the street, or so on and so forth, they don't understand the premise for which these medications got FDA clearance and are being used by practitioners for the effect they're being used by. They are being used because they were proven in randomized controlled, double-blind randomized controlled studies that they worked, right? So you have to look under what conditions did they work.
Mm-hmm.
You need to replicate that in your clinic. And this is where I'm going to the very top of this episode, and I'm going to give you guys a big shout out. And this is something that I think this part of the, and this has been, man, I cannot tell you how profound this has been for me. This has been seriously, I know it sounds, I know, and I'm prone to, it sounds like hyperbole, and I'm prone to hyperbole, but I'll take that. But
as
but
his brother, I could attest
you can attest that. But seriously, these people, what did they do? They didn't just come in for a shot every week, and that's another thing too. Don't send them home. Bring them in every week. Talk to them. Counsel them. You get to check for side effects, and there's an accountability aspect. So don't just send them home with some shots and come back in a month. But these people they adhered to a regimen. That regimen was 150 minutes of exercise per week. So 5 days a week, 30
which
minutes
is a
straight.
minimum requirement for diabetics. That's where that 150 minutes comes from.
There you go. Okay. That's okay. I didn't pick that up. Excellent. That's why we're a team, dude. All right. Okay. So there you got that. Plus, they had counseling. Plus, they had nutritional. So they had counseling for lifestyle changes, adherence to them, and nutritional counseling. And they all followed the same diet, which all I could see described in the study was a quote unquote healthful, balanced diet, whatever that was. But basically, what you need to be doing is higher in proteins, lower in carbs, fat intake. I don't know where the science stands on that, and there's a lot of that in around. But cut out the fried foods, cut out the processed sugars, increase your protein. You don't have to drop all the carbs, but make them a smaller portion of your meal. And then they had to have a deficit of 500 calories a day compared to what they were eating.
Oh, okay. I didn't know that.
Yeah. So they had to have regular counsel sessions. They had to meet with a nutritionist. They had to have healthful, balanced meals, higher in protein, lower in carbs, a deficit of 500 calories a day in their nutrition intake, 150. So when you come into the office, it's our job. We're doing a disservice. We're not telling you that, because if you think you can just come in and get a shot, most people honestly will lose weight because of the effects.
They
the drugs
lose
are so
weight,
powerful.
yeah.
But you need to know that you need to know a couple things. You might be resistant or deficient. And hey, if you're not losing weight, are you adhering to the protocol in the study for which this drug was touted based upon these results? You have to replicate that if you're going to truly say it doesn't work for you. Well, are you really adhering, right? And here's something really interesting, okay? For the people like you and me that talked about lifestyle changes, guess how many people were able to make – now, so you have a placebo group, right? This is randomized controlled. Oh, here's something interesting. This is a cool feature. I'm going to give a shout out to Eli Lilly in this. And did you know that they were so good about the randomization and the double blind, the people that were getting the placebo, the saline or whatever they were injecting to them, sub-Q,
Namasaline.
the namasaline, they were changing the doses every 4 weeks. They were they were going to that level of detail. So these people were getting 0.5 more normasaline, turns out. So they really thought, so the people in the placebo group got very similar body weight changes with pretty significant results. 70% of them look at the mean weight reduction, 70% on lifestyle changes alone, but it was 95. It was like that extra 25, 30%, almost 30%. So it was absolutely statistically significant to a large degree. But what shocked me was that, wait, on average, 70%, well, it was like 69 something percent. So roughly 70% of these people
without the drug.
Without the drug. So what did that mean? That means 150 minutes of exercise a week, diet changes, coaching, counseling, nutrition, exercise. I mean, so if you're going to really help people sustain weight loss, and you've got to do it, I think this model is the way to go, right?
Yeah, For sure.
Don't you think? Now, and so this is what I love. So then I saw this. This study just came out last week, and you've been doing this at Midtown or something similar to it now. Now I would say it's in its mature state or near. You've been doing this for years. Looks like
Yeah,
that's
that
what
was
we
the
should have been
model
doing.
that we tried to practice out of. And honestly, I don't force patients that they have to do those
No,
things, but I tell them, included in the price of the medication, includes the price of our clinic, is access to our nutritionist. You come in, you can weigh. We have the gym, and so some of my patients take us up, some of us don't. We've teetered on whether or not to make that a requirement of the medication, and whether or not to make it not a requirement. And so at the moment, it's not an absolute requirement. But yeah, that is the model with which we are attempting to practice out of from a significant standpoint.
so we got to do that. And so much was I encouraged by this frame shift. I mean, we all knew we had to do it, but putting it all into one medical practice that people can avail themselves in a convenient, cohesive, interdisciplinary group like you guys have done in Midtown. We're going to do that. That's our next transition over here in Myrtle Beach. So, because this talking about pandemic, this is the pandemic. Obesity is the pandemic.
For sure.
There was a 2014, and this is so almost 10 years old, McKinsey report. Obesity, so the top 3 killers worldwide: the morbidity, mortality, impact on economy, bad things that can happen to humans from a medical perspective, were smoking. They're all the same, or all tied rather. Smoking, firearms, and that could be suicide, it could be war, it could be homicide, accidental fire, all of those lumped together, and then obesity, all about $2 trillion. That was 10 years ago. And now they're estimating that half of the U.S. population in the next couple of years is going to be type 2 diabetic, half or greater than half. It's insane. This is the real pandemic. This is, and so when I saw these data, when I saw this biochemical mechanism, when I had this level of understanding, it totally changed my idea about these medications, where these people were coming from, and what we could do for them. One last thing I'll tell you is, in learning about incretins and the way that you can become resistant to the incretins and the way you need to become more sensitive to them, just like insulin sensitivity is a problem, like in type 2 diabetes, right? And we call it T2DM, right? That you have to set the stage to lose weight and allow these medications to work and allow your body to work by becoming more sensitive. You need to increase the sensitivity to those hormones because you become resistant over time from higher levels. Basal levels of insulin, for instance, is a good model, right? The way you do that, turns out the people that have had the greatest reduction in weight in my clinic, guess what it was? People that we did a hormone profile on, and they were hormone deficient, testosterone in the cases of a menopausal woman, testosterone and estrogen. You optimize their hormones, holy cow. And you add this, people. So what are you doing? You're sensitizing the body to burn calories faster. You're going to combat that innate problem of all weight loss, by the way, not just this drug, but all weight loss, is that there's going to be some muscle loss too, right? You do that by adherence to resistance training, not just cardiovascular, but resistance training.
Yep.
That's the key. Pack on the muscle, increase the number of mitochondria, increase your testosterone receptor count, increase your sensitivity, burn the glucose better, and become more fit in the process, right?
Yeah, in my clinic, I see a significant reduction of A1Cs from just testosterone replacement in men.
100%.
Simply testosterone
Absolutely.
replacement, you get an A1C
well
reduction.
Documented in the literature, and it's overlooked. I mean, it's a massive benefit, right?
Yeah, those two, testosterone deficiency and type 2 diabetes, really run together at a certain age for a male. So to tie it back, to help me, so when I tell patients, I kind of lay it out like this. So would this be a good synopsis of what you said? That there's a couple different mechanisms with which the tirzepatide and the semaglutide work, right? So we have the slowing of gastric emptying, which gives you feeling fuller longer, so you eat less. You have
at the brain level too.
And then you have an appetite suppression at the brain level, which seems to dip a little bit into addiction realms, so to speak, or alcohol consumption realms as well. And then
Yes,
you have the improvement of your metabolic profile from improvement of your diabetes profile. Those are the three sort of synopsises that I give to patients. Is that correct?
absolutely. And don't forget, here's another interesting thing when you hit it from the hormone side. You're going to increase dopamine. We used to think we decrease serotonin. Now we know we increase serotonin with testosterone, but hormone optimization. If you're in a dopamine deficient state because of lifestyle, doom scrolling on social media, porn addictions. I mean, that's I'm not into the analysis of that, but that is one that we know about. Just different things. You may be somebody who gets a dopamine hit from food, so there's a reward system that comes,
Correct.
right?
It's the same. It's a very similar. That's how I describe it to patients. It's a very
100%.
similar mechanism.
Right.
Yeah.
Now you fix that to some degree. Not again. We always said that it's on the show from the very beginning. It's not a panacea, but testosterone will increase that. You don't have that basal, or you have a less of a deficiency of dopamine, so to speak, right? And so that's going to improve it to help you make those lifestyle modifications. But you become more sensitive. Yeah, everything that you said. So here's everything you just said, and then I take that. That's how they work, and then I would say. Oh, in addition, the GIP too, and to some degree the GLP help you metabolize and burn fat a little bit better. And that's not as well described in the literature that I could find, but it definitely there's some effect there too. But
Okay.
here's what you want to do is you're setting the stage and you want to make your body sensitive to insulin, incretins, and one of the ways to do that is resistance exercise in general, and optimizing your hormones. You want to pack on muscle and lose fat. You want to increase your basal metabolic rate so that you're in a calorie deficit. And the way you do that is hormone optimization, resistance training. They're all hand in hand. Then these medications work. They're at their that's when they work the best. Your glucose metabolism gets better. And by the way, it's not just diabetics. And turns out that these effects that lead to diabetes or in the diabetic state, they occur way sooner than we ever thought. Because by the time that you're quote unquote diabetic, you've lost anywhere from 65 to 85% of your pancreas beta cell function. That's massive.
So I want to, as we come to the end of that, and you've done a great job with the literature, I want to hit you with some of just a couple questions that I've received. Actually, I had one of them yesterday. And so I'll put you on the spot. I didn't give you any pre-warning on this. So side effects. So there has been described in the literature a few case studies, as I understand it, of increase of depression and or suicide ideology. And have you seen that? Do you have any input on that? From what I saw in the studies, there was no correlation from taking these drugs and increases in depression, increases in suicidal ideation, and or a drop in efficacy of patients' medications. Is that your experience?
Yes, that's my experience. I don't think the literature bears that out. Did you say you did see that in the literature? In
I
the
saw
popular literature or the scientific literature?
Scientific literature that there was a study that they looked at the efficacy of depression medications and semaglutide, and the semaglutide did not interfere with the efficacy of the depression medication.
It's not. It's not on the drug monograph. It's not. I've not seen it bear out in the literature. You can have decrease in your basal production. Interestingly, you could have. I'm sorry. Like for instance, if you're on GERD medication and your GERD comes back, it's because you got a gastroparesis, and and you have an increase in your acid production because of these medications. So you have to be careful with that. So in that scenario, yeah, but I've not seen any link to. In fact, I'm not saying link to depression or suicide ideation, nor do I know of it in the literature. And in fact, I've had several people tell me that they had an enhanced mood on the specifically enhanced mood.
That's what I see. I think it comes from, regardless of what we think or want to think about people's weight and how it influences their interaction in society, there is still, for a lot of people, a stigma of how they look from an aesthetic point of view and how that influences the rest of their life. And when you change that for somebody, there can be a significant change in their mood to a positive sense.
For sure. And I will also say we have a couple patients, and as I've gotten to understand the literature better, understand the medication better, and apply it in the clinical realm, I have seen less of this. But early on, there was some frustration with people that weren't losing weight, and so there was not to the level of frank depression, but there was, significant frustration. Just these
Right.
people they felt like this was going to work for them, and they had this answer that they've been searching for their whole life, and it turns out there is something to that they were in the state of GLP deficiency or resistance, it turns out, but I've not seen any frank depression.
Okay. Next question.
One thing I want to tell you though is, just real quick, I will add, there have been people who have reported to me things like bone pain, cardiac like palpitations, things like that, and the diabetic state would lend itself to osteopenia and osteoporosis due to its effects on bone metabolism. GLPs tend to decrease osteoclast activity and increase osteoblast activity. So they tend to build bone, if anything, and getting your glucose right tends to be better for your bones than not. But what I did find interesting is why it's not on the drug monograph, and I've not seen anything in the literature. It was interesting to me that GLPs, there are receptors on osteoblasts and osteoclasts. So that was shocking to me. There's even receptors of GIPs in the heart, and so I had to I had to swallow my pride. I didn't think that there was any relation to that. I didn't see the drug monograph. And then the patient complained of that, and I saw, it's something else that you're dealing with. Went and researched it. Now, there's nothing described. There's not like, there's an absolute link to certain, atrial dysrhythmias or atrial fibrillation. But just the fact that there are receptors on the heart makes you wonder. And one of the things that I learned early on in my medical career was to listen to patients, not to dismiss them. There's always something there. Now, it could be supertentorial, and they could be conflating things or mixing things up, or there could be, they're pinning it on something else. But I always try to rule that out first. And in so doing, I found, wow, these receptors are on all these end organ tissues that I didn't realize they were. So
next question. Side effects, the most common that I see is gastrointestinal nausea. Specifically, it's the number one side effect that we're running into. Secondarily, constipation, which on my semaglutide has not actually been that big of a problem. I tell my patients that I think in my clinic we run into less of that, and honestly, I don't see a whole lot of it, but I also taper my dosing a little bit, and I try to find the lowest effective dose. Would you agree that it makes logical sense that at potentially lower doses, you're going to have less of those side effects, and that larger doses, you would have more of those side effects?
Absolutely, because the effect of the incretin on the gastrointestinal tract is dose dependent and on the hypothalamus, meaning that not only are you going to change motility, but constipation may be a function of something as simple as dehydration and also electrolyte imbalance, right? So you have to have the right electrolyte balance to have good smooth muscle cell contraction, etc. And not having electrolyte imbalances can lead to ileus and constipation, things like that. Even on the monograph, they talk about hypovolemia. So think about this. If it's decreasing your appetite, you may decrease your water intake and your fluid intake as well as just food. So you have
exactly what I tell my patients.
Exactly. Yeah. So you have to caution patients not to get dehydrated. People have early kidney disease or things like that. While it does help them from a diabetic standpoint, like the flow study, etc., you have to remember it can lead to hypovolemia. And there's been cases, and before I started prescribing these medications as a functional medicine practitioner or a wellness physician, as a surgeon, I would see people occasionally come in with what was perceived as a bowel obstruction, and it was from use of the semaglutide and different things. And so in some cases, the constipation can be profound and get you into trouble. Okay.
So
that's rare.
I like to titrate my dose. I tell my patients one of the principles we're working out of is I want to find the lowest effective dose for you that may be a little bit lower than standard protocols, or maybe a little bit lower than your friend. So we're not going to compare dosing to dosing. And sometimes the slower, more consistent route is the better route to avoid those side effects.
That's number one. Number two is, and I'm glad you said this because it jogged my memory to, or stimulated me to say this, that one thing we have to remember too with all medications is the pharmacokinetics. And patients definitely forget that, or they just don't even know about it, understand it. But I find that practitioners oftentimes forget that. I see this in residents, I see this in nursing staff, and all kinds of different practitioners. Myself, I forget about it sometimes. But you have to remember that to get to a steady state in a medication, and that would be the state at which you would expect to see the most profound or important physiologic effects, right? That steady state, it takes about 4.5 half-lives. That's what that's the pharmacokinetic rule of thumb. Guess what the half-life of semaglutide is? A week. So you're talking about a month, a little bit over a month to get to a steady state. So be patient. So yeah, we're going to go slow, but also you got to remember we're going to be patient. And I'm going to go slow too to avoid those side effects, but also because a low dose first dose is not going to be the same as a low dose at a steady state. And
correct.
You see, so you at a month of shots is way different than you of at 1 day of shots. And the reason is the steady state. So give me some time to show you, and hang in there and be patient.
Yeah, so I tell my patients, my way of stating it is the first 2 weeks, my main goal is for you to have no side effects.
Right.
That then we've met success, because they're wanting to lose weight. They're like, I didn't lose any weight the first week. And I'm like, well, that wasn't our goal. Remember, our goal is to have no side effects, see how your body tolerates it, see what your response to this is. Then we can, after those first 2 weeks, then we can start to see some potential changes in titration.
And you'll see people, and maybe you've noticed at your clinic. I've noticed that when I started to remember to tell patients about the pharmacokinetics and be more cognizant of it and that kind of thing, I went back and look at people are starting to really get more profound weight loss at around week 3, week 4, week 5. And I'm like,
it's a week 4 or 5. Yes.
I mean, it makes sense, so
it makes sense.
Yeah. What's your other
Doc,
question?
That was it. That was my 2 big ones. We're kind of running out of time. So those are the 2 big ones, that the nausea and that's the most common side effect. I had one patient ask me about suicide risk this week, and I thought that was interesting. And lo and behold, on a side note, that led us down a conversation that ended up, she didn't walk away with the medication because for her, when we talked and I asked questions, she was there at maybe the behest of somebody else as opposed to the behest of herself. And so that I was like, well, let's maybe take a week or so to think about this and talk about this, and let's have another conversation. Let's not maybe start this right now. So that conversation kind of led us to another route that it wasn't even maybe the genesis of this meeting that I was having with her for weight loss wasn't even of her own volition, so to speak.
Well, that's more about understanding your patients, trying to maintain your emotional quotient, your EQ, and patient autonomy. The last couple of things I'd say is the contraindication, of course, is the thyroid cancer, specifically multiple endocrine neoplasia history, family history. So that's the only contraindication that I've seen thus far. And then other dangerous ones would be, pancreatitis and cholelithiasis or cholecystitis. That, for instance, the New England Journal of Medicine, I think it was the Surmount 1 group that came out in July. It was about less than 1%. And that's what I've seen in semaglutide studies too, about 1 or less than 1% cholelithiasis. If you have rapid weight loss, you'll have cholesterol, kind of a simple way to think of it is kind of coming out of the bloodstream and forming stones, these cholesterol stones, which there's 3 major stones that you can have in your gallbladder. The cholesterol stones are the most common. So that's probably more a function of that, but it also is on the GI tract and bile flow and things, but it's really rare. The other thing is that these medications create beta cell and pancreatic hyperplasia. So sometimes those acinar ducts, they're called, where they kind of cells surround the central lumen, they can kind of get so big that they kind of squeeze it shut and you get obstruction of pancreatic flow. But I have not seen a single case of pancreatitis. However, if somebody had a previous history of it, was for some reason we thought was prone to it, or had gallstone pancreatitis, or was a severe drinker, I would be very careful with those patients. But yeah, I've seen nausea and constipation have been the biggest problem, and those have not been severe in my experience. Have they not been severe in yours?
No, not at all. Not even they're really just something to be mindful of. I tell patients, if you already struggle before you walk in the door with constipation, we probably should plan ahead of this and start with some Citracel right off the bat. So, I mean, we're not talking just adding some fiber supplement over the counter, and that takes care of it for the most part. But I haven't seen most of the nausea that I've run into seem to be moving too quickly on dose changes,
Yes.
or at the dose change, right? That week 4 to week 5 change, that week 9 to week, or so I guess week 8 to week 9 change. Those changes tend to be the bigger ones.
It's interesting that you say that, because in the in the studies, that's exactly what they found too. Was when you did that step up. That when they did a step up, that's when they, in the dose, that's exactly when they would have the predominant.
You go from 0.25 to 0.5 milligrams.
Yeah. Hey man,
well, awesome, Doc.
It was a good time. I guess we'll see you next time to talk about females on testosterone.
Testosterone in females, yes.
Let's do it. All right,
brother.
Take care, man.
Appreciate it.
Okay, bye.